So, to begin with, what is pharmacology? We can clearly say that pharmacology consists of studying the mechanism of action of drugs, evaluating their efficacy and safety use, and defining conditions for safe use. So, pharmacology studies the drug as a molecule, as a substance, how it interacts within our bodies, where it will go, what will it bind to, and what will be the consequences of this binding. What are the different branches of pharmacology? In pharmacology, we have so many branches, and on top of them, we have pharmacokinetics, which study the journey of the drug from the moment that it is administered to the moment where the active ingredient is free to bind to its receptor and do its pharmacological effect. Pharmacodynamics study everything that comes after pharmacokinetics, where the drug is free to bind to its receptor and where it will exert its effect. Toxicology, pharmacoeconomics study the economical effects of a drug or a pharmaceutical procedure, for example. Pharmacogenetics, the effect of genes. Pharmacotherapeutics, where to give a certain drug in what disease and what it will do. Pharmacometrics, pharmacoepidemiology, and pharmacognosy. These are only some of the many branches that we have in pharmacology. So, how is a drug developed? How is it discovered? And where does it come from? The process of drug discovery involves several steps to transform initial hits from a screen into marketable drugs. Here's a summary of how this process works. First, we have the initial screening. In the initial screening, we get a huge amount of potential drugs, but in most cases, these drugs are not valuable, do not have the exact pharmacological effect that we need, but they are something that we base our further research on. After the initial screening comes the role of the medicinal chemist. The medicinal chemist comes here and starts creating derivatives of the hits that we found in the initial screening, and they only aim to explore and define the SAR, standing for structure-activity relationship. This helps in optimizing various parameters such as affinity for the target, because we want our molecule to correctly bind to its receptor. Absorption and distribution in the body. Sometimes we get molecules that may have a good pharmacological effect, but they cannot be administered because they have some chemical properties that stop them from being correctly absorbed and distributed in the body. So medicinal chemists come here and start creating or editing the molecules. Metabolism, agonist or antagonist activity, permeability across cell membranes, unwanted side effects. So all these characters are the aim or the reason why medicinal chemists spend a lot of years trying to correct molecules that were obtained in the initial screening. Third and fourth steps are now computerized. The use of structural information. X-ray crystallography provides detailed structural data if the target protein can be crystallized with the lead drug. Molecular modeling and computational chemistry. These techniques use structural information to suggest chemical modifications that might improve the drug's fit with the target and thereby enhancing its affinity. So now, these computational approaches have not only identified new uses for existing drugs, but also explained failures of some drugs in late-stage clinical trials, highlighting their potential to streamline and enhance the drug discovery process. New magnetic resonance NMR studies, they also provide structural information about the drug receptor complex, but with a lower resolution than X-ray crystallography. However, NMR studies are much easier and much more used nowadays. Computational drug discovery. The ultimate goal is to achieve drug discovery entirely through computational methods. So, how? First, we have a database. Using a database of detailed chemical information about millions of compounds, and another with structural information about all human proteins. Screening. Virtually screening chemicals to find those with high affinity interactions with the target protein. Interactions. Screening for unwanted interactions with other proteins. And finally, predictions. Predicting the structural and functional consequences of drug binding and relevant pharmacokinetic properties. Let us now move to the different types of receptors. Now, we said that the drug has to bind to its receptor. But we don't really know what are these receptors and what are they made of, where they are inside our body. So let us take an example or an idea about them. We have first the receptors, the normal receptors that are found on plasma membranes of cells. This is the plasma membrane and these are our receptors. We also have enzymes like methyl dopa on dopa decarboxylase and simvastatin on HMG-CoA reductase, which is an enzyme involved in cholesterol synthesis in our bodies. We also have ion channels like benzodiazepines on GABA-gated chloride channels. We have carrier molecule like cocaine on noradrenaline uptake. And also we have the famous nucleic acid inside our DNA. Drug receptor interaction process. How does it happen? Now, we have inside our body physiological receptors. These receptors, they bind to certain ligands and act as regulatory agents. Among them, we have the neurotransmitters like norepinephrine, acetylcholine, dopamine, serotonin, and others. These neurotransmitters are involved in the transmission of orders from our nervous system to other organs, within our nervous system, etc. We also have hormones like epinephrine, insulin, cortisol, the stress hormone, estradiol, and others. And also we have autocoids like histamine, prostaglandins, and others, which are involved in allergy, pain sensation, and whatsoever. What are the functions of these physiological receptors? First, they have to recognize the ligand. Ligand recognition is identifying and binding specific ligands at the ligand binding domain, because inside the receptor we have a certain domain that is specific to this ligand. Transduction. Transduction means converting the ligand binding event into a cellular response. And finally, the transmembrane signaling and signal amplification, and that means mediating and amplifying signals through receptor-coupled effector systems. Drugs are classified into specific and non-specific drugs. Specific drugs are exogenous ligands that interact with physiological receptors at a certain site, and this site is nothing other than the ligand, the endogenous ligand binding site. Agonists are specific drugs that bind to physiological receptors and mimic the effects of endogenous ligands at the same receptor site. So, the agonist here comes, bind to the receptor, and we form the drug receptor complex. And then we have the pharmacological effect, which is the effect of an agonist that is mimicking the endogenous effect. An agonist has an affinity, has an intrinsic activity, has full agonistic properties, and intrinsic efficacy. And here you can see some examples of agonists and where they act. Second specific drug, we have the partial agonist. Partial agonists are agents that produce a submaximal response. So they are agonists, but their response or their effect is minimal compared to the effect of full agonists, regardless of the drug concentration. They have lower intrinsic activity and efficacy than full agonists. Inverse agonists exert opposite pharmacological effects of a receptor agonist. So, if I have a ligand that, when bound to its receptor, gives, let's say, an antihistaminic effect, our inverse agonist will give histamine-like effects when binding to this receptor. Antagonists are drugs that oppose the pharmacological effects of agonists or endogenous ligands. They can be classified into pharmacodynamic antagonists, where they have to be bound to the receptor to exert their antagonistic activity, and non-pharmacodynamic antagonists, where they bind to different sites, different than the receptor site, but they exert the antagonistic activity. Pharmacodynamic antagonists are also classified into competitive and non-competitive antagonists. Competitive antagonists are sometimes reversible or irreversible. These competitive antagonists, they bind to the ligand binding site on the receptor in order to exert their antagonistic effect. Here we have some examples of competitive antagonists like prazosin, which is an alpha-1 blocker that is used in the treatment of benign prostatic hyperplasia, also known as BPH. And we also have some non-competitive antagonists. These non-competitive antagonists, they have to bind to the receptor as a whole, but their binding site is different than the binding site of competitive antagonists. Otherwise speaking, that they bind to the receptor but not to the ligand binding site, to be more specific. Now, when it comes to non-pharmacodynamic antagonists, we have different antagonistic mechanisms: functional or physiological antagonism, pharmacokinetic antagonism, and chemical antagonism. A famous example of non-pharmacodynamic antagonists is the antacids. An antacid does not have a specific target or ligand binding site to bind to. It is simply a chemical formula that, when administered, will neutralize the acidity of the stomach without binding to any receptor. Now, in an ideal world, the drug would bind to its receptor, would exert its pharmacological effect, and then would go away. But unfortunately, it is not the case. We usually encounter mechanisms of tolerance where drugs are no longer of the same efficacy that they used to have when they were first administered, because the body or the receptor develops mechanisms of tolerance. For tolerance, we have pharmacodynamic mechanisms like receptor desensitization, where we see downregulation of receptors, the number of receptors decreases, uncoupling of receptors from effector system, desensitization as a mechanism of drug resistance to agonists, We also have receptor supersensitivity, where we encounter receptor upregulation, changes in receptor sensitivity, and finally we also have the receptor translocation. For pharmacokinetic mechanisms of tolerance, it's very logical. We can see that the body will decrease the plasma drug concentration, and therefore the concentration at the site of action of the drug will decrease. Or it will increase the drug metabolism, and therefore the drug will be eliminated more rapidly. And finally, we have cross tolerance. The cross tolerance means tolerance to one drug leads to tolerance to all drugs belonging to the same family. Here you can see the dose-response relationship between a drug and its effect. Here we can see log of the concentration of the agonist and the percentage of the maximal effect. If we look closely to this, we see two drugs, drug X and drug Y. Drug X is being administered at increasing concentrations, and the same goes for the drug Y. Now, if we take this point here we call the EC50, the effective concentration 50. This means that this amount is the amount needed of the drug X to obtain 50% of the maximal effect. Now, if you were to compare the EC50 of drug X with the EC50 of drug Y, we can see that it is clearly much less than that of drug Y. How can we translate this reading? Simply, what we can say is that drug X is much more potent than drug Y. Comparing EC50 means comparing potency, because we needed much less concentration of the drug X to obtain an effect exactly the same as that of drug Y, but with higher concentrations. Okay, so here we will see a comparison between a full agonist and a partial agonist. If you look closely to this, at first we were giving increasing concentrations of the full agonist, and we were seeing the response increasing gradually. When we started administering the partial agonist here, we saw this huge shift in the maximal effect after administering both the full and the partial agonist. And with the increasing concentration of the partial agonist, the maximal effect was taking much more longer to appear than with the full agonist. Now, what does that mean? That simply means that the partial agonist is occupying the places that the full agonist was going to take. And this prevented the maximal effect from being seen until the partial agonist was to be eliminated and taken over by a full agonist. In the graded dose-response relationships, we quantify the occurrence of a specific response in response to the dose of drug employed. And that simply means that the effect of the drug will increase gradually as we are increasing the concentration. We saw that in the graded type, the effect will increase gradually with increasing concentrations of the drug. However, this is not the case in the quantile type, or the type known as all or none. Here, the assumption is made that the individual units of the system respond to a given criterion or not at all. So here what we can say is that the effect of the drug is whether seen or not. Let us now define some general pharmacodynamic terms. The ED50 value, or the effective dose 50, is the dose of the drug to which 50% of the population responds, and it represents the median effective dose. Now, LD50 value, or the lethal dose 50 value, is the dose of a drug that is lethal to 50% of the treated population, and it denotes the median lethal dose. The therapeutic index, or the TI value, is calculated as LD50 divided by ED50. Therapeutic index value provides a measure of the safety margin of the drug. The certain safety factor, or the TSF value, this value is determined by the ratio of LD1 to ED50 to ED99, representing a specific safety factor for the drug. The standard margin of safety is calculated as LD1 minus ED99 multiplied by 100 and divided by ED99. The standard margin of safety provides insight into the relative safety of a drug by comparing the doses causing minimal harm, LD1, to those producing therapeutic effects, ED99. Now, we said that the drug has to go through all the pharmacokinetic steps in order for it to exert its pharmacological effect. Let us now mention some of the factors, only some of them, that might be affecting the pharmacokinetic parameters of the drug. First, some factors affecting absorption are the pH, because we know that for a drug to be absorbed, it has to be in the non-ionized form, because otherwise it will not be able to pass the plasma membrane. So if the drug is ionizable and it is put in a medium where it will be ionized, then it will not be absorbed. Also, we have the gastric emptying, how fast the stomach empties its content, the molecular size of the drug, and the lipid solubility of the drug. Some factors affecting drug distribution. Now the drug is absorbed and it has to be distributed. What are some of the factors that affect this step? First, we have the binding to plasma proteins, because when the drug is bound, it will not be absorbed and it will not be able to pass any membrane. The blood-brain barrier and the cerebrospinal fluid. The blood-brain barrier is protected from so many molecules, and this allows the brain to be protected from many drugs and substances that if they cross the blood-brain barrier, they will definitely damage the brain. Fat as a reservoir. Some drugs are very lipophilic, that they can go inside the adipose or the fatty tissue and stay there for a very long time. And this affects the distribution of the drug. How? It might be stored there for a certain period and then be redistributed again. Now, redistribution is also related to fat as a reservoir, but we also have the enterohepatic recycling, where the drug is eliminated in the bile, but within the enterohepatic circulation it is reabsorbed again. Factors affecting drug metabolism are very wide and numerous. Some of them are drug-drug interactions. Because why do we have drug-drug interactions? Because inside the liver, we have proteins and enzymes that are involved in the metabolism of drugs. And when administering multiple drugs at a time, they might be competing on the receptor or on the binding site inside the liver to be metabolized. Pathology if the patient is ill, genetic factors if the patient has a certain genetic mutation in a protein that is involved in the drug metabolism, and of course age. And finally, some factors affecting drug elimination. Physicochemical properties of the drug, because we know that the drug has to have certain chemical properties in order to be eliminated in the urine. And one of the most important ones is that it has to be hydrophilic, because hydrophobic drugs are not eliminated in the urine. Plasma concentration of the drug, urine pH, blood flow to the kidney. If the blood flow to the kidney is not sufficient, the drug will not be correctly eliminated, and then it will have an exaggerated effect. And the disease state of the patient, of course, it will affect how well their kidneys function.